Bismillah ar-Rahman ar-Rahim. We welcome you all to the 16th annual conference of the Department of Obs and Gynae at Cairo University. And we need to welcome you all for 2 long days of over 120 presentations. I will ask Professor Ahmed Abu Nasr, the head of our department, who has been very supportive and very helpful over the last few weeks, to give the welcoming speech. And we need to express our gratitude to the presence of our Dean of the University, Professor Fathi Khudair. And obviously, we need to thank all of our professors and all of our attendees and our executive committee who have been working hard with us over the last few months. Thank you. Professor Ahmed Abu Nasr.
صباح الخير أولاً. Good morning, everybody. This is the 16th annual conference of the Department of Obstetrics and Gynecology, Cairo University. The title is Unity and Diversity of Gynecology and Obstetrics. First, I would like to welcome our Dean of the Faculty, Professor Dr. Fathi Khudair, Dean of the Faculty of Medicine, Cairo University, and before that, he is a known eminent plastic surgeon. Thank you very much, Professor Khudair, for being with us and your support to our department. I would like also to welcome our international guests who are participating as chairpersons and speakers. Also, our chairpersons from all the universities, research centers, armed forces, and police, and all the speakers from all over Egypt, and of course, all the participants in our conference. This year, we have adopted further the international standards concerning conference website, continuous all through the year, and also we have the accreditation of the European Council of Accreditation for Continuous Medical Education, 11 hours total, 6 hours in the first day and 5 hours for the second day. And you can see that we have adopted the barcode that can be read through the entrance of the sessions. Also, we have this year expanded the conference to accommodate more speakers. We have, for the first time nationally, 3 parallel specialized sessions. We have expanded the sessions, we have expanded the exhibition area to put at your hands all the new things in the industry. Our conference in numbers, the sessions are 23. We have 46 chairpersons from our department. We have 33 chairpersons invited. The speakers totally 122. From our department, 47, and from outside, from all over Egypt, 75 speakers. I would like to thank all the coordinators and faculties of the pre- and post-conference workshops. They did a great job. We have already finished 4 workshops, and still we have 3 more workshops beginning from Saturday and Sunday. This year, we have named 3 new coordinators from the young generation in our department, 3 young assistant professors to coordinate the workshops, and they did a great job with our faculties. The faculties are full of young generations from our lecturers in our department. On behalf of our department, I would like to thank them very much for their effort. Special thanks should be gone to our Secretary General of the conference, Professor Dr. Ahmed Zakaria. And by the way, last year, Professor Zakaria was assistant professor, and he was the coordinator, the first assistant professor as a coordinator in the ultrasound workshop dealing with the first trimester workshop with Professor Kapros Nikolaides. Also, special thanks go to our conference executive board, Professor Dr. Gamal Abdel Samia, Professor Dr. Ahmed Suleiman, and Dr. Ahmed Mahmoud and Dr. Nadine Sharif. The title of our conference is Unity and Diversity of Gynecology and Obstetrics. Why we have chosen this title? Our conference title this year reflects the increase in subspecialties and simultaneously stresses their belonging and connection to our main specialty, gynecology and obstetrics. I have been motivated and inspired to choose this title to explain and stress that in spite of the expansion of obstetrics and gynecology and the evolution of new subspecialties, these subspecialties are depending on and connected to the main specialty itself. What is the current status of our specialty now? Actually, internationally, there are 4 established subspecialties, namely general gynecology, including urogynecology, gynecologic oncology, assisted reproduction and endocrinology, and obstetrics and prenatal diagnosis. Actually, endoscopy and ultrasound are present in all the established subspecialties. I would like you to think of our specialty as our heart and the subspecialties as the circulation going from and coming back to the heart. In the past 3 to 4 decades, gynecology and obstetrics has been exploring new frontiers for the benefits of our patients. New technologies and instruments have been implemented in improving screening, diagnosing, and treating patients. The diversity of the established subspecialties should strengthen the unity of gynecology and obstetrics specialty. They resemble the various colors that form and constitute the beauty of one picture. Subspecialties are like the branches of a tree. They are interconnected and also connected to and depending on the main trunk, that's to say, gynecology and obstetrics. Cutting the connection between the branches and the main trunk is a useless, detrimental, and futile action. Finally, enjoy the diversity of our specialty in our conference and maintain its unity. Thank you very much. I have the honor to present our Dean of the Faculty, Professor Dr. Fathi Khudaid, to address you in this opening ceremony.
Bismillah ar-Rahman ar-Rahim. Good morning, everybody. Thank you very much, Professor Ahmed Abu Nasr, for this invitation for a great meeting. Thank you, Professor Ahmed Zakaria. I'd like to thank everybody in our gynecology and obstetric department. Yes, I am a plastic surgeon. Now I'm the dean of the faculty. And of course, everyone here knows what Qasr Al-Aini, as we call it, or Cairo University School of Medicine is. It's the oldest school of medicine in the Middle East and Africa. It has a very, very long history of 173 years. It started in the days of Muhammad Ali, who decided to initiate an Egyptian army, and at that time he decided to build a school of medicine to help the army doing what it should be doing. And it started here on the other side of the River Nile. And now it is this big, huge school that has hospitals with 5,200 beds, and it has 9,200 undergraduate students. It has 5,450 postgraduate candidates. Gynecology and obstetrics is one of the most active departments in our school. It's concerned with women, and women are very important in our country, especially in these days of change. A lot of us Egyptians say that women changed the country in the last 3 years. Maybe They were the first line of change in this great and ancient country. Plastic surgery also is a very important branch in our school. And both of these branches usually have happy endings. I usually tell my patient, we are like gynecologists and obstetricians. We have a happy ending, so you should be going into the operating room feeling happy, because when you're with an obstetric specialist, you deliver a baby. When you are with a plastic surgeon, you get a better looking face and body, which is something great. So I would like to welcome you all. I hope you have a great event. I hope everything will be nice and well organized. I trust and I'm sure of our department that they can bring out a very, very successful event for all of you, especially the young doctors coming from all over the country to learn. We promise, and I think Dr. Ahmed Abu Nasr also promises, a great event. Thank you very much. I wish you all the best.
Thank you very much. And now, after 5 minutes exactly, we'll proceed in time with our plenary session. Thank you very much.
Ladies and gentlemen, our colleagues and guests, in the name of God, Bismillah ar-Rahman ar-Rahim, welcoming all you. On behalf of the organizing committee, it is our great pleasure to welcome you in the 16th annual conference of the Department of Obstetrics, Cairo University Faculty of Medicine. Today, we have caliber, distinguished chairpersons, speakers, and hot subjects to address. It will be an excellent gathering for us to exchange scientific information, knowledge on the latest advances in gynecology and obstetrics, as well as we hope to be a social scientific event for teaching and gathering of friends. We hope that all will enjoy the Congress and will interact, and this will stimulate a creative exchange of ideas and will be personally rewarding. Now we will start our plenary session. I will address to you the head of the department, Professor Abu Nasr, elegant, distinguished, honest professor. He will address to you a subject which is perinatal counseling and diagnosis of Gaucher disease in Egypt, 15 years experience.
Chairing panel, dear colleagues and guests, my talk is about prenatal counseling and diagnosis of Gaucher disease in Egypt. This is our 15 years experience from the year 2000, Dr. Fatin or Professor Fatin and myself. To who doesn't know, Professor Fatin is the ex-vice president of the research center and the founder of the biochemical genetics department in the National Research Center. She has been working in the field of inborn errors of metabolic diseases for more than 25 years. What's Gaucher disease? Gaucher disease is an inherited lysosomal storage disease. Results from an autosomal recessive deficiency of glucocerebrosidase enzyme with consequent accumulation of glycolipids in macrophages of reticuloendothelial system, particularly in spleen, liver, bone marrow, and lung. Diagnosis is confirmed after demonstrating a decreased acid beta glucosidase activity in lymphocytes. There are three phenotypes: non-neuronopathic, characterized by anemia, thrombocytopenia, hepatosplenomegaly, skeletal pathology, and bone marrow infiltration. Type 2 and type 3 are neuronopathic types, type 2 acute and type 3 chronic. Our objective was prenatal counseling and diagnosis of Gaucher disease in pregnant females with previous affected sibling or siblings. Primary intervention is prenatal counseling. Prenatal counseling was done in the period from June 2000 to November 2014 in 87 pregnancies among 64 females. 1 patient was counseled in 4 pregnancies, 6 patients counseled in 3 pregnancies, and 8 patients counseled twice in 2 pregnancies. Female age ranges from 18 to 38. All the 64 pregnant females have an affected sibling with Gaucher disease, except one with family history in close relative. 4 of our patients have 2 affected sibs. After first counseling, 46, that's to say 68% affected sibs were living, and in 21, that's to say 31% affected sibs were dead. Prenatal counseling concerning the enzyme replacement therapy, among the 46 affected living sibs, 21, that's to say 45%, were under enzyme replacement therapy, and 25, that's to say about 55%, not under enzyme replacement therapy. And I will say later on why. Among the 21 affected dead sibs, 3 were under enzyme replacement therapy before death. 1 died after 2 years of enzyme replacement therapy. Another died after 5 injections of enzyme replacement therapy. And 1 died 3 days after enzyme replacement therapy from a bloody diarrhea as a complication or side effect. In our prenatal counseling, we asked about normal children. Among the 64 pregnant females at their first visit, 35, that's to say about 55%, have no normal children. 29, that's to say about 45%, have normal children. 14 have girls, 12 have boys, and 3 have girls and boys. That's to say, and I want to stress about this point, that 49, that's to say about 77% pregnant females have no normal boy. And that's very important in our country. Consanguinity rate in our country is very high, and it is more high or higher among the inborn errors of metabolism. Among the 64 females, we have about 87.5% positive consanguinity. And sometimes I say double consanguinity, ولاد عم وولاد خالة في نفس الوقت, double cousins, and 12.5% only negative consanguinity. If we consider the 87 pregnancies together, we will have nearly the same result concerning consanguinity. What are the important explanations to be explained to the patient or the pregnant lady during counseling? And this may apply to any counseling of a genetic disease. First, the nature of Gaucher disease. Number 2, possibilities of recurrence as a recessive, autosomal recessive disease. It is 25% recurrence. Idea of prenatal diagnosis, available test of prenatal diagnosis, and as we are using the chorionic vellus sampling, we should explain the exact procedure of chorionic vellus sampling. Finally, an informed consent was given by the pregnant female, and she was scheduled for prenatal diagnosis. The secondary intervention, prenatal diagnosis, chorionic vellus sampling was done between 11 to 12 weeks gestational age. CVS was done in 65 pregnancies among 50 females, 3 times in 4 females in repeated pregnancies, and 2 times in 7 females. Beta glucocerebrosidase activity was measured in chorionic villi. Chorionic villi were sampled by transabdominal route using the freehand free needle aspiration method with 20 gauge needle under simultaneous ultrasound guidance. If sufficient villi were not obtained on the first attempt, a second pass was made. If we look to the number of punctures, they should not be more than 3 punctures. We have obtained enough successfully chorionic villi in 62 cases. by one puncture in 39% nearly, and two punctures in 37%, and we needed third puncture in 15 cases, or that's to say 24%. The chorionic villi were immediately dissected from the maternal decidua. The sample was placed in sterile media or saline and frozen. Beta-glucocerebrosidase activity was measured in chorionic villi fluorometrically. The primary outcome about the cases subjected to CVS. Of the 87 counseled pregnancies, about 75% proceeded to CVS, and 25 were not subjected to CVS for various reasons. 11 did not show up at scheduled time. Maybe they are aborted and they didn't report. 4 already came late for prenatal diagnosis because in doing CVS, we are doing it between 11, 12, 13 gestational age. 5 had missed or spontaneous abortion, 1 refused, and 1 had induced abortion before prenatal diagnosis. Secondary outcome, the enzyme activity. Beta-glucocerebrosidase activity was measured in 62 chorionic villus sampling. 74.2 revealed normal activity, that's to say normal fetus, and 25.8 revealed low activity, that's to say affected fetus. In 3 cases subjected to CVS, we couldn't retrieve enough chorionic villi for the biochemical diagnosis. Now I will speak about controversial issues regarding prenatal diagnosis. 3 questions are addressed. Why prenatal diagnosis in spite of the presence of enzyme replacement therapy? Why CVS and not amniocentesis? Why enzyme assay and not mutation analysis? Why prenatal diagnosis? There are many limitations of enzyme replacement therapy. First, it is lifelong. Many patients experience disease progression when treatment is stopped, so treatment interruptions are not recommended. Secondly, it is expensive. It costs between $100,000 to $400,000 US annually. Third, the rate and degree of response to therapy is variable due to several factors. And the last one, and very important, it doesn't treat neuronopathic symptoms, because neuronopathic symptoms among Gaucher disease up till now are non-treatable. Enzyme replacement therapy, there are variable response. These variable response depend on several factors: age at presentation, concurrent medical conditions, organ affected, and presence of irreversible pathology. Concerning enzyme replacement therapy in our country, an important question always: who will pay? Who will pay the cost of these patients? This is a controversial and ethical issue that raises a lot of arguments. First, the family. Most of our patients are from poor families that cannot afford to pay the extremely expensive therapy. Second, the insurance companies does not cover treatment. The government, there are other health needs, especially in a developing society. Non-governmental organizations, not a priority in their restricted resources. Actually, we are depending up till now upon donation. And there is a very restricted donation and not accommodating too much patient or new patients. Why chorionic villus sampling? CVS is done at 11 to 12 weeks gestational age, affording 3 to 4 weeks earlier diagnosis than amniocentesis, done at 14 to 15 weeks. Why enzymatic diagnosis? Beta-glucocerebrosidase assay is accurate. Detection of many mutations is too expensive and time-consuming. What's very important, phenotypic expression cannot reliably be predicted by genotype, as severity may vary among siblings or even in identical twins. Also, mutation analysis does not add more information relevant to decision making. Many factors affect decision making. First, personal experience and suffering with the affected SIB, absence of a normal boy, proper prenatal counseling, family and society pressures, also negative influence of other doctors. نصف المعرفة هو جهل أيضا، مش نصف يعني نصف المعرفة هي جهل كلي. So if you looked to our explanation of the dropped out cases, we have 11 cases no show up at scheduled time. Our explanation, maybe this is spontaneous abortion, or discouraging family influence, or negative influence of other doctors, or maybe fear from procedure or facing results. 4 cases came late, maybe also for lack of knowledge about availability and accuracy of perinatal diagnosis, or also discouraging family influence, negative influence of other doctors, or hesitation to come for counseling. 5 cases had spontaneous or missed abortion. That is because every one of us know that abortion rate is high among genetic diseases. Last, that one patient went for induced abortion and one refused, and maybe they were not convinced by the rationale of prenatal diagnosis. What is the examples of the negative influence of other doctors? This is the comments coming to us from our patients. They say that some doctors in their villages or in their area, they said, no prenatal diagnosis for such disease. Tests are neither accurate nor conclusive. Tests are for research and not for clinical practice. Placenta is not formed in the 3rd month for CVS, or CVS will harm the fetus or will definitely cause abortion. Abortion incidence among CVS related is less than now in 0.5%. In conclusion, in spite of the presence of enzyme replacement therapy for Gaucher disease, it is not effective for all types in addition to high cost and variable response. So, prenatal counseling should offer early prenatal diagnosis by chorionic villus sampling as an option to allow couples at risk to make an informed reproductive decision. Finally, I would like to share with you some of the ethical recommendations concerning the prenatal counseling and diagnosis. Prenatal counseling and psychoanalysis. What is the idea? Prenatal counseling is not a one-way meeting. Enough time should be given for listening to couples, understanding their problems and fears, and explaining clearly and patiently all the available options, including prenatal diagnosis. Prenatal counseling should be comprehensive, non-judgmental, and non-directive. Prenatal counseling should be considered as a psychoanalysis session in which psychoanalysis tools and techniques are used. What are the techniques and what are the tools and what is the aim? First tool, listening to the patient. The technique or act by expressing her thoughts and inner conflicts. The aim is talking as a relief. Number 2, the tool is analysis by the counselor, acting by liberation from outer pressures, from family or society or other doctors, and the aim is removing negative thoughts and influences. Finally, explaining medical options, acting by offering help, the aim, finding solutions, and encouraging positive attitude. Counseling is not a pre-diagnostic process only. Counseling is a pre- and post-diagnostic process. But it is different between pre and post. Because in the pre-diagnostic counseling, we are explaining